Good morning, and thank you for joining us for the global panel discussion on evidence-based impact and outcomes of supply chain transformation in healthcare. I'm Martha Huston, and I'm the president of SCAN Health, and I will be your moderator for today. The mission of SCAN Health is to mobilize knowledge and research evidence to accelerate, scale, and measure supply chain transformation in healthcare. I've been in healthcare about 30 years, 25 of that in the supply chain arena. And I don't think there's ever been a time where we need to understand and improve supply chain more than right now. It's critical to the health and safety of our populations and will continue to be top of mind until we get the pandemic under control. The panelists today have been leading this effort around the globe, and we're really lucky to have them to speak to their experiences. Given though the uncertainty of schedules with our, given the uncertainty of the schedules of our presenters, we did pre-record this session in late October. We were afraid that they would be called away to deal with pandemic issues, and we wanted to make sure we had their insights and knowledge and ability to engage with us throughout the panel discussion. We do though have several of the panelists available online, and you'll be able to engage them in the chat box, and you can find the chat box to the right of your screen. Through this panel, we hope to share how a digital and automated supply chain infrastructure can enable health systems to manage the impact and spread of COVID-19, facilitating the efforts to keep their population safe and healthy. As Dr. Barrett shared earlier in his opening keynote, having this infrastructure in place has many benefits, chief among them enabling clinicians to focus on patients and improve overall safety in the healthcare supply chain. These are critical needs long before and will be long after this particular pandemic is over. And now it gives me great pleasure to introduce our panelists. First is Dr. Joseph Drozda. He is a cardiologist and the Director of Operations Research at Mercy Health. Mercy is a 4-state regional health system headquartered in St. Louis, and is one of the 5 largest health systems in the United States. Dr. Drozda is active within the Healthcare Transformation Group. This is an action-oriented collaboration among 6 leading U.S. health systems with a focus on sharing best practices and driving needed change across the healthcare supply chain. His current research is using real-world data to evaluate the safety and effectiveness of medical devices. Joining us from the UK is Dr. Kevin Fenton, who is the Regional Director of Public Health England and Public Health NHS London. In this role, he oversees national prevention programs and leads the health equity portfolio with a range of programs and activities focused on addressing the social determinants of health and promoting settings-based approaches to health improvement. Dr. Fenton is also a member of SCAN Health's Board of Directors. Next on the panel is Dr. Susan Moffatt-Bruce, the CEO of the Royal College of Physicians and Surgeons of Canada. Dr. Moffatt-Bruce is also a professor of surgery and biomedical informatics at Ohio State University and sits on the GS1 Management Board. Her passion for quality and patient safety, strengthened by an extensive background in business administration, has culminated in more than a decade's work in continuous improvement. She will bring a unique perspective to the panel as a healthcare leader and clinician. And our final panelist is Dr. Verna Yu, who is the president and CEO of Alberta Health Services in Canada, which is a single health authority responsible for promoting wellness and providing healthcare services across the province. The principal focus of her initial role with Alberta Health Services was quality and patient safety, engagement, leadership development, and fostering relationships between medical staff and the healthcare system. Dr. Yu is also on SCAN Health's Board of Directors. Through this session, our goal is to enhance our understanding of how health systems are managing the pandemic, discuss the challenges they are facing, and hear about the opportunities and value of how an integrated supply chain can provide solutions and a roadmap forward.
So thank you again all for joining us, and we look forward to learning more about how your health systems and organizations are managing the coronavirus pandemic, the challenges you faced and the challenges we know you continue to face, and the opportunities that you see and the value of an integrated and digital supply chain infrastructure. So with that, we're going to jump into our first question, and we're fortunate today to have panelists from around the globe, so we really want to get their varied perspectives. When COVID-19 first emerged in your jurisdiction, what impact did it have on public health and health systems? And we're going to start in the United Kingdom with Dr. Fenton. So Dr. Fenton?
So thank you very much. So the COVID pandemic has had a severe impact on our society and many communities across the United Kingdom. Not only were we hard hit in the first wave of the pandemic with high deaths and excess mortality from the infection, it has also had a profound impact on the organization of health care systems as well as the public health system. To date, over 40,000 individuals have died from the coronavirus pandemic in the United Kingdom, and certainly London has been hard hit as the capital city here in England. We have sustained significant impacts ranging from excess mortality within elderly people, significant impacts on health inequalities with a disproportionate impact of the epidemic, especially among minority communities, those who are socioeconomically deprived, older individuals within the society, with mortality rates among those aged over 80 being nearly 70 times higher than those aged under 40 years of age, and significant differences by gender as well. A number of population-based surveys have been done which have uncovered some of the reasons for these inequalities. And we know that there are a variety of factors which determine both the risk of exposure to the infectious disease, factors which increased the risk of severe disease, progression to severe disease and mortality, including the prevalence of multiple long-term conditions and non-communicable diseases, but also factors which are associated specifically with mortality as well. In addition, studies have also really highlighted some of the social and structural factors which have driven inequalities with the UK epidemic, and which has had a disproportionate impact in driving susceptibility to the disease and its impact. These include, for example, the high prevalence of individuals who are affected who were care workers and occupied key occupations within the society, including health and care workers, security guards, transportation workers, jobs which place them at high risk of being exposed to the infectious disease or a high degree of probability of contact with others. We also know that factors such as multiple long-term conditions which are poorly controlled had a significant impact on severe disease and mortality as well. As we prepare for the second wave of the epidemic, I think there are a number of lessons which have been learned, which we are now taking into consideration as we prepare for this phase of the pandemic. Number one is the importance of ensuring that we have strong systems in place to ensure robust testing, contact tracing, linkage to care for all individuals who may be at risk of acquiring infection and for those who may be symptomatic with the disease. Second, ensuring that there is sufficient capacity and resilience within the health and care system to ensure that the NHS is able to cope, both in terms of protecting healthcare workers, but ensuring that patients are also identified and managed in as safe an environment as possible. Third, ensuring that our care homes and social care system, which had been hard hit in the first wave of the epidemic, are well protected through routine screening, attention being paid to infection control, and working with patients and family members in terms of limiting infectious disease, spread of infections from the community into the care home system. And finally, a key learning is looking at the robustness of the wider system to ensure that we're operating as one to develop much more tailored and regionally applied approaches to controlling the infectious disease, including more tailored regional approaches to introduction of behavioral and social interventions, more tailored and regional and local approaches to scaling testing and contact tracing, and of course, a more efficient use of data to understand both the evolution of the epidemic and how and where responses should be applied and intervened. So a lot of lessons learned as we approach the second wave that we'll be bringing to both understanding systems and how systems respond to the pandemic. Thank you.
Yeah, thank you, Dr. Fenton. Dr. Drozda, could we get the US perspective, please?
I guess I can't give a perspective for the entire country, but I can talk about the experience that we've had here at Mercy. We're a 4-state regional health system in the central portion of the country, servicing Missouri, Northwest Arkansas, Southeast Kansas, and Oklahoma. We have about 40 hospitals, ranging from large tertiary care hospitals in St. Louis and Springfield down to critical access hospitals in small communities in our service area. So we saw a wide variety of issues related to COVID as it began to be manifest in the earlier part of the year. In the March-April timeframe, we were hit primarily in the St. Louis area, and with relatively little disease in the rural or outlying areas and in Oklahoma. And as things progressed through the summer, we saw sort of the reverse of that. Things stabilized in the St. Louis area, whereas the disease began to become much more manifest in our other service areas. So we experienced things from in the St. Louis area from issues related to residents, in particular in our African-American populations, early in the epidemic in particular. Then we saw issues with disease in the poultry industry in Northwest Arkansas that got a lot of national attention. So we saw a wide variety of challenges, which presented a tremendous challenge to us because we had to be prepared to manage the pandemic in multiple different markets, experiencing multiple different prevalences of disease. So it was something of a challenge that we had to meet, and we did so by instituting a command center, much as many of the health systems around the country did, to help and stay on top of all the data that's coming in, both clinical, supply chain, et cetera, to be able to make instantaneous decisions, real-time decisions on things like personnel, equipment, ventilators, PPE, et cetera. So it's been a major challenge for us that we've, I think, eventually got our arms around, although we are beginning to experience a second wave in the St. Louis area. Some of that's related to individuals coming in from surrounding rural communities, and we're still challenged with staying on top of it.
Thank you, Dr. Drozda. And Dr. Yu, can you share with us the Alberta and Canadian experience?
Absolutely. So I would like to sort of represent Alberta, which is one of the provinces in Canada. We have a population base of about 4.3 million people. We've had about 21,000 plus cases and a total of 287 deaths. Our total hospitalizations since March have been over 1,000, with about 200 in ICU. We've had over 1.6 million tests performed. And in fact, on a per capita basis, we have one of the highest testing rates in the world. We've had to reduce our clinical services and reduce non-urgent surgeries when COVID hit. And in May, when we relaunched clinical services, we've been doing it gradually and now are about 90% of pre-COVID numbers in terms of clinical care and surgeries. We also oversee long-term care in Alberta Health Services, and about 85% of our sites actually have not had COVID cases, which we're very grateful for, and that's due to a very robust quality assurance program that we've had in terms of audits even prior to COVID. We actually were anticipating the arrival of COVID back in December of 2019, and we've been preparing for it initially through our procurement supply chain, which I'll go into a little bit more detail with a subsequent question, but other aspects of how we prepared would include lab innovations, because early on there actually was no test for COVID. You actually had to develop your own recipe through PCR testing, and so we actually developed that recipe early on in January, anticipating that we're going to get COVID early on in the year, and indeed we did get our first case of COVID on March the 5th. Part of the planning also took place around our provincial coordination center, which is part of our fundamental foundation for emergency disaster management. And so we actually set up Our PCC, again, early on in January, we linked it to nodes to all parts of the system, including our medical officers of health, acute care, seniors care, community home care, EMS, addictions, mental health, indigenous health, corrections. And it was very important to link these delivery programs with our provincial centers of expertise, including communications, which is so paramount, as we know, IT and technology, HR, corporate services, as I said, our contract and procurement supply chain, laboratory, public health contact tracers, and so on and so forth. It was very, very important to ensure that we had a coordination of approaches and really aligned strategies during a time of very rapid and tumultuous change. So for example, we've got over 2,000 documents and guidelines that we've used to support our staff. We've centralized our staffing processes to ensure that we have the right people in the right positions throughout the province. And we've had to plan and expand recruitment in areas where there has been tremendous need, including HealthLink, which is our 811 call line, where our calls have tripled, contact tracers, where we've increased our staff by more than tenfold, staff for our assessment centers, to list a few of those requirements. Innovations have also been taking place at a pace that's really been unheard of prior to the pandemic, including, as we know, increase in virtual healthcare everywhere. Innovations on online tools. We were the first, I would say, in North America to develop an online assessment tool for the public to see if they're at risk for COVID. And we've shared this now, not just broadly within Canada, but other jurisdictions, including New York. And needless to say, central coordination with data informing decision-making in an integrated provincial healthcare system has really been a huge asset in our ability to deal with the pandemic.
Thank you, Dr. Yu. Just to follow up on that, you mentioned starting some of your preparation really even back in December. And I know that you had stockpiled medical equipment before COVID really struck. And then you were able to help some of the other Canadian provinces with masks, with gloves, with ventilators. What really enabled that preparedness? What was it that had you off to an early and smart start?
Yeah, and you know, part of it even goes before the pandemic. I think that one of the things that we've done exceptionally well is that we've actually developed very, very strong relationships with our vendors. And I think we can't underestimate the importance of those solid relationships. AHS is now 11 years in existence, and we've had a lot of changes and improvement in our contracted procurement and supply chain management team. And over the past decade, we've not only been more efficient with consolidation, with savings over $300 million, but under the great work of our leadership with Jitendra Prasad, we've really invested in developing the relationships, which I said was absolutely critical. So for example, we've heard of stories where some of the supplies that arrives at a doorstep were not useful, or were supplies that weren't up to the medical quality. Well, even before the pandemic, we had a process in place, for example, in China, where we actually had a team in place in China to actually inspect the supplies, make sure that they were of quality, high quality insurance. And then we would load it onto the charter planes that we would charter, and then they would come over to Alberta, ensuring that there weren't any stops along the way, because we knew that some of the supplies actually got stopped or prevented from proceeding further. And so we had those processes in place already. The other thing is, again, as I said, there were so many requests for different suppliers, and it was very, very hard to know sort of the validity of some of the supply requests that we were getting from vendors. And again, having those strong core relationships with vendors really allowed us to be able to put in really, really good large numbers of supply requests. The other thing that was very, very important for us is the data. You know, I know in Alberta, in our province of 4.3 million people, I know our exact burn rate. So for example, our daily burn rate for procedural masks is about 33,000 a day. At the peak of the pandemic in Alberta, which was sometime in April, May, we actually utilized 760,000 masks a day. So you can imagine we actually had to model what it would look like in terms of the different scenarios about how much our supplies would need, that we would need to get in order to make sure that we had enough supplies in place for at least 2 weeks, if not 2 to 3 months. And so that was absolutely critical for us. It actually, I would say, really asked our teams to diversify some of the supplies that we were ordering from, so that we weren't just putting all our eggs in one basket with a certain country. We knew exactly where some of the supplies were coming from, so we would go to some of the other countries that we weren't necessarily always in partnership with. And so it's very, very critical to have the data in place to be able to model the numbers that we would need so that we can actually always be a step ahead of the game.
Thank you, Dr. Yu. Dr. Drozda, how did the Mercy system respond to some of the challenges with sourcing personal protective equipment during this crisis?
Fortunately, we had in place a rather robust supply chain system that allowed us to use GS1 standards at the point of care and for clinicians to know exactly what they had in inventory and what was available to them at our central warehouse located in Springfield, which services our entire health system. So they could tell what they had on hand, what we had at the warehouse. They could communicate directly with supply chain as things were used, so that items could be reordered. So it was really a management system. Sourcing was a bit of a challenge initially, and quite frankly, there was a bit of panic, and there was some hoarding behavior, et cetera, at our various institutions. But once this management system swung into place, people began to get confident in it. We could actually take a look at not only what was on the shelf and not only what was at the the warehouse, but supplies that were in transit, in the pipeline. Not only that, we had predictive analytics using BI tools, business intelligence tools, that were helping us on the clinical side as we monitored the pandemic, such that we could predict with reasonable accuracy what the demands for PPE were going to be in our various hospitals. That allowed us to stay ahead of the curve, such that the central warehouse could then ship PPE to where not only where they were needed now, but where they were going to be needed. Sort of the Wayne Gretzky approach for all of you Canadians. He did play in St. Louis too, by the way. So I think what happened over time was that our clinicians got a lot of confidence in their ability to manage, and the fact that PPE were there when they needed them. So we never really ended up in any sort of crisis mode where we were having problems. We did have to reuse one-time use PPE for a period of time, but that ended in May. And I think we're at a point now where we're confident with it. We won't have to reinstitute that sort of intervention.
Okay, thank you, Dr. Drozda. So it sounds like both Alberta and Mercy, through the use of data, through being prepared and having good plans in place, were able to manage through this. I know many health systems, though, were not adequately prepared, and as we know, they ran into a massive shortage of personal protective equipment. Dr. Moffatt-Bruce, from a clinician perspective, how did you work through the scarcity of supply?
Great, thanks very much. I just want to share maybe a little bit of my own experience, but also maybe the experience of my colleagues, and also that what we've heard from physicians and residents in Canada as well, internationally. You know, working through a crisis, working through a pandemic, really initially was a part of the acceptance that there was a problem. And I think that truly once clinicians and team members accepted this, then, you know, everything kind of fell in place thereafter, but it took a tremendous amount of energy. You know, the PPE was recognized as truly being a challenge. It was in shortage. However, I think it was a signal that it was actually about changing the entire way we cared for patients. And so while supplies were in shortage, we also had to think about how to get access to care for those patients with COVID and those without. So there were a couple of parts of this, of a successful response. The first was really understanding what was the educational resources that were needed to help us understand what was going on and how we had to pivot. Online resources, online rounding, virtual meetings, virtual connections were entirely new. around it, just to the magnitude to which we had to implement. Secondly, I think really importantly was the interprofessional teams that had to come together to address this issue. And so in many instances, teams had to come together that had never worked together. You know, the word supply chain became a clinical word. It no longer was someone else's responsibility. It had to be truly a clinically integrated entity, and that brought power to a solution. Communication was absolutely key throughout the pandemic in addressing the shortages. And there are many times in the day when team members would say, gosh, I just got another message, you know, they've changed the message again. And in all reality, it was because things had changed again. And so communication in all kinds of modalities was really, really important. And then lastly, I think just human resilience got many teams through this. Residents, physicians, nurses, administrators, teams that had never worked together in such a united fashion really were able to come together to not only address the supply issues, but the care issues. And I think ultimately provided outstanding care to our patients. Thank you.
Okay. So, thank you. Do you think the health systems could have pivoted more to support the clinical teams?
I think the health systems pivoted very well to support the teams, considering we were in the midst of a pandemic. I think it took a lot of energy, and I think it took a lot of resources to do the pivoting in order to be responsive. And that's probably something that we need to look at as we go forward. But I think ultimately the care that was provided really was top quality, but it took a tremendous amount of energy and resources in order to do that.
Okay, thank you. You know, hindsight's always so clear. We've all been through a number of experiences here with this pandemic, but knowing what you know now, what would you have done differently to manage the whole situation? And we're going to start with Dr. Fenton.
Yes, hindsight really is 2020, but the reality is that we continue to learn as we go through successive waves of this pandemic. And I think there are three key lessons that are clearly emerging, certainly from a public health perspective here in the UK. So the first is ensuring that the basics of infectious disease control are in place and are available at scale at the level required to control the epidemic or certainly mitigate its spread. And this includes managing the demand for testing and looking at not only testing within clinical settings, but in community settings, ensuring that we are providing much more widespread testing in a diverse range of formats so that people who are symptomatic can get tested, diagnosed early, and isolate to reduce the spread of the disease. And associated with an effective testing program, ensuring that we scale up our contact tracing as early as possible. And certainly that's one of the core lessons that we've learned, and we're currently doing that now in the UK, both in terms of contact tracing individuals, doing the sort of forward contact tracing, but also doing more effective backward tracing to identify sources of infection, to identify super spreader events, and to manage disease control in the community more effectively. Second, I think there are lots of lessons learned about the use of PPE, who gets access to it, when it should be used, understanding how to effectively manage both procurement as well as the distribution of PPE, and ensuring that our supply chains are robust. Certainly we have now moved towards more manufacturing within the UK and looked at supply chains both within Europe and globally to ensure we have sufficient stock that will be appropriate for subsequent waves of infection. Third, as mentioned by other colleagues, clear and consistent and culturally competent communications are really critical for both this second wave of the pandemic and subsequent waves. The most common complaint that we had from both healthcare providers and members of the public was just changing guidance, changing expectations, confusion on what's expected of providers as well as patients and the public at any given phase of the pandemic. And the more that we have become proficient in providing clarity of message, clarity of purpose, and clarity of strategy in managing the pandemic, we can see the benefits of that for local communities and the local response as well. Fourth and finally, I think one of the things that we would have done differently, and it's certainly understand that, as with other infectious diseases, they're not randomly distributed in the population. And given our experience with both other respiratory epidemics, but also other infectious diseases, planning for and mitigating the impact on inequalities upfront is certainly going to be a key part of the second wave and subsequent waves. So recognizing the work that needs to be done with those who live in more deprived areas, those who have poor access to curative services, those who are unable to take up population prevention measures, whether it's isolation or not social mixing for whatever reason, because of the jobs that they do, because of their social and economic backgrounds. It means that we need to plan for these eventualities and these realities for members of the public, and to assist them in order to take up the preventive measures as needed. So I think these are some of the core lessons that we're certainly taking forward, and certainly what we would do differently in terms of mitigating the impact of the disease in this wave and subsequent waves.
Okay. Thank you, Dr. Fenton. Dr. Yu, Alberta certainly had a number of processes in place, but what would you go back and have done differently to manage this pandemic?
Yeah, I think, as was mentioned, in retrospect, it's always easier to go back and I think be critical, but I don't think any of us have dealt with a pandemic before. So I think, at least within Canada, I think we've, I think we've done a good job in terms of, working with government and government policies to ensure that we, do what we need to do in terms of trying to reduce the spread of COVID. Coming back to Alberta Health Services, though, we've actually had a history of natural disasters in Alberta about every 2 to 3 years, interestingly enough. And in fact, it's about 3 years since our last natural disaster, which is the wildfire in Fort McMurray up in northern part of the province. And we were kind of anticipating that we would get another natural disaster. We just didn't think it would be a pandemic. After saying that, though, the difference that the pandemic did for us was that, the pandemic is all-consuming, because it is the only business that we did in addressing the issues around COVID-19. So when you look at natural disasters like wildfire or floods, those types of disasters, they tend to be fairly local. And so the structures that we have built in place to support that type of localized disaster is different, and has to be different from a pandemic where that is the only business that you're doing. So about 4 to 5 weeks into the planning on the pandemic, we realized that we actually had to readapt Alberta Health Services in terms of the interlinkages between the executive team, the C-suite of the organization, with the infrastructure that was developed that would be normally there to deal with a natural disaster. And so we actually had to rejig the whole way that we worked because of the fact that that was the only thing that we're doing. I think the other thing that we focused a lot on, and to be frank, I'm not sure that we could have done any more, is the communications, which is absolutely critical, that Dr. Fenton had already mentioned, but really is critical. And not only is it communications from within the organization, but we actually, because we are the provincialized healthcare system, we actually are relied on externally for a lot of the external communique. So making sure that it aligns with the government directions and strategies is actually really, really important. And people were just thirsty for it. We used to have communications that were going out every single day of the week. Eventually we went down to, 3 times a week, twice a week, and now we're weekly. But the communications, I can't emphasize enough the importance of that. The third thing I think that was very, very important for us is really making sure that we support the teams. Because things are happening so quickly, if you didn't have the communications, it would actually be very confusing, and people are tired. They're not only people working in the healthcare system, but they're also family members, and they're also in the public realm. And so really making sure that we actually have the supports in place. We obviously went to work from home, which is a phenomenon that many of us weren't used to. So providing those supports, and then obviously supplying the supports that we needed for the frontline workers who, as you know, were obviously very stressed. So I think the emphasis on workforce is actually really, really important. And, again, having an integrated system, I couldn't emphasize enough how important it was for us to be able to redeploy workforce in the areas that we need it more and the most, especially, for example, in the seniors facilities. You know, we are able to actually do that very nimbly, and that was very, very important. And just a fourth point I just really want to highlight also that was mentioned by Dr. Fenton was the importance of local supply chain sources, because, you know, at one point we were not able to get our 3M masks, for example, up from the US. And so we were struggling to decide, well, where are we going to get it? We actually went over to Europe at that point, but really trying to maximize local products, local suppliers, I would say, is really going to be critical for anything going forward.
Okay, thank you, Dr. Yu. Dr. Drozda, what would you say that Mercy would look at differently now that they've been through this experience?
I think what our experience has actually shown us the way forward, and some of the things we put together because we had to are going to be permanent, and they're going to put us in a position to be able to respond to not only future pandemics, but actually to manage healthcare in between pandemics in a much better fashion. Now, at one point, Mercy, quite frankly, was a collection of semi-independently operating hospitals that just sort of used the larger organization as a way to leverage pricing. But as a result of the pandemic, we've accelerated a process we'd already begun that we call One Mercy, so that we're now taking advantage of the large organization to be able to manage through crises like this and actually to meet more efficiently and effectively take care of patients all the time. That started with our supply chain organization some years ago and has now migrated into the clinical space. We further integrated supply chain and clinical care, such that I think supply chain is now recognized as a vital part of clinical care, and that the clinicians have to help in the management of inventory of things like PPE and other consumables, and that's to their benefit and the benefit of their patients. I think going forward, we will continue to increase our sophistication with respect to data and our ability to use modern tools like business intelligence, natural language processing, etc., to give us great clinical data and to integrate it, quite frankly, with supply chain data in a way that helps us manage patient care in general. And let me just say something else too. I failed to mention this before. When the crisis started back in the March-April timeframe, we actually formed an alliance with the 3 other major health systems in the St. Louis area that we now call the task force. That task force was an agreement among those different independently operating health systems to share resources to manage what we were worried at the time was going to be an overwhelming number of COVID cases. The task force has been able to keep track of the pandemic in the St. Louis area with sophisticated data, the type I've quite frankly, not seen from any other location in the United States. So I think this bringing us together as a system, showing us that alliances with other hospital and health systems in our region, it can be a benefit to everyone, I think is going to be ongoing. It's not just for this particular pandemic, and will put us in good stead to meet the next crisis.
Okay, thank you, Dr. Drozda. That's encouraging relative to those alliances that it unfortunately took a pandemic to create, but to your point, you can certainly see the benefit on an ongoing basis. Dr. Moffatt-Bruce, what would your experience have you done differently with the pandemic?
Well, I think relative to what I would have done differently, probably backs it up even further than pre-COVID, is really having clinicians, all types of clinicians, engage in understanding the business and operations behind healthcare delivery. I really think that we now have to train our staff, our healthcare entities, in how we really for healthcare. It's not enough to simply be able to be a doctor. I think we have to be really thoughtful about the delivery mode as well.
You've all touched upon what some of the experiences you've had. Would impact how you would approach the pandemic in the future. But, you know, as your organizations are looking to address perhaps a second wave and address future pandemics, what other practices and programs are they planning and preparing for so that you are better prepared? And let's start with Dr. Yu. Verna?
Great, thanks for that question. You know, we've actually done a bit of an overview already in terms of the organization to what we're calling beyond COVID and trying to capture the learnings that we've had up to this point. And there's no question that there are always opportunities for improvement. And I'm just going to list a few of them just based on what we had gathered. First and foremost is to make sure that we maintain the momentum by adopting structures and processes to make sure that we manage our priorities and streamline decision making. Obviously, with a big healthcare organization like Alberta Health Services, we have to make sure that we remain nimble and flexible and adaptive during times of these waves. And you don't get a lot of lead time, as we know. The need for increased collaboration and knowledge sharing is really important, and not just within the organization, but externally with our academic partners, with industry, with innovation groups. The other thing we need to think about is consider more permanent, flexible working from home, again, making it more easily the workplace environment for employees to be able to adapt to the current situation that they're in. Virtual healthcare, again, needs to be maintained, expanded up and down. The ability to ramp up and down is going to be really critical. Optimizing use of up-to-date technology, as I said, you know, was very important for us to do online assessments that we started with. Then we moved on to the online booking for any appointments for assessment centers. And now we actually have adopted texting so that we actually text the COVID results back to Albertans. So really trying to make sure that we keep that momentum up on that. And then obviously to make sure that we dedicate and restructure our resources to be able to maintain and enhance critical functions. And all of these, I would say, are things that build into a resilient organization. And that's what we need to be during the time of COVID, is to be resilient.
Thank you, Verna. Dr. Moffatt-Bruce, your comments?
Yeah, I would agree with all that's been said thus far, and I would just add maybe building redundancy into our systems and understanding what and how we do that will be really important. You know, to be vulnerable in the next pandemic will mean that we haven't learned from what great work has been gone on thus far. So I really think understanding where the redundancy needs to be and to be thoughtful about that will be helpful going forward.
Thank you. Dr. Drozda?
So at Mercy, we're working in 3 different areas: communication, technology, and data. On the communication side, we've seen the need to get the word out early to all of our providers, all of our hospitals, all of our clinicians, with respect to what we're doing when we face crises like COVID. This sort of communication is important to the business and the clinical care generally, and will greatly improve the way we work with all of our co-workers. On the technology side, we've learned the importance of remote care using virtual techniques. We have a virtual care center that we opened a number of years ago as one of the first buildings in the world to be devoted completely to virtual care. We've now seen how it needs to be improved and applied within our health system to the patient care, and I think we're going to see an expansion of those services that will continue into the future well beyond COVID. On the data side, our command center has learned how to use data in real time to make critical decisions that impact patient care. In this case, it was for COVID, but going forward, it has multiple applications. We will continue to increase our sophistication in terms of artificial intelligence, natural language processing, etc., to help us in the care of individual patients and patient populations. And further, we're going to continue our alliances with other health systems to combine data to help us in evaluating patient populations and to benchmark against each other. We're currently working with several other health systems on a project to support one of the vaccine developers to monitor patients receiving vaccines far into the future to look for effectiveness and safety issues. So I think the learnings for us are work on technology, work on communication, work on data. These are critical tools to use in the management of populations even outside of a pandemic.
Thank you, Dr. Drozda. And Dr. Fenton, if you can weigh in on this question as well.
Yeah, so I agree entirely with the other panelists about the importance of communications, better use of technology. And I especially agree about the importance of surge capacity within the system, both within the health and care system, but also within the public health system as well. So the ability to scale up, especially workers who understand aspects of community engagement, contact tracing, being able to find, test and trace individuals both within the community as well as high-risk settings is going to be critical. So the ability to flex that workforce is going to be a key part of planning. I had three other perspectives, though, in terms of lessons that we're bringing to the next pandemic. The first is the importance of pandemic exercises that we do. We've always had a good tradition of doing tabletop exercises on planning for pandemics. I think this has given us an opportunity to understand both the limitations, but also the value of that training, the importance of having a wider cast list of partners involved in those planning exercises, and much more accountability for ensuring that the recommendations and results of those exercises are in fact implemented or inform policy and our programs. And then second, given what we know about inequalities, certainly with this pandemic, preparing for subsequent pandemics about how do we mitigate the impact on future infectious disease threats on the most vulnerable. And what does it mean for the way we design programs, the way we do our communications campaigns, the way we engage leaders within communities, or the ways in which we develop programs which provide a baseline level of health and well-being so that communities are far more resilient for future waves of both this pandemic and other pandemics would be critical. We've learned about the importance of poorly controlled non-communicable diseases, including diabetes, hypertension, as risk factors for severe disease with COVID. And certainly for future pandemics, we will really need to look at the drivers of risk and how we mitigate that within our communities as well. So I think these are some of the additional things that we'd certainly bring to planning for future pandemics. Thank you.
So we are so grateful for our panelists today in providing a wealth of insights and perspectives on how they manage the impact and spread of COVID-19 by relying on their digital supply chain processes, data communications, and want to also thank the panelists who were able to engage in the chat box today. We know you have very demanding schedules and really appreciate your time. The experiences, lessons learned, and strategies shared will be extremely helpful to all health systems as we continue to manage the impacts of the pandemic. And as I mentioned, the panel was taped, and I'm sure if we had an opportunity to speak to our panelists today, there would be additional lessons they've learned and insights they could share. So we'll look forward to continuing that study. I mentioned in my introduction, the mission of Scan Health is to mobilize expert knowledge and research evidence to accelerate, scale, and measure health system supply chain transformation. I want to thank you all for helping us achieve that goal today by sharing the stories with our participants. And participants, thank you for mobilizing this knowledge as you return to work to transform your supply chain.